Now, so we spoke about what are the complications that can happen in a patient, how to prevent them and treat them. We spoke about what it should be the normal checklist when we see a patients every day in the wards. Now, whenever patients have a stroke, definitely there are going to be certain deficits, like motor weakness. So motor weakness or weakness of muscles of a patient is seen in stroke, and that is measured on the MRC scale for strength on a grade of 0 to 5. So depending upon the strength or power of the muscles of the affected side, patients undergo a passive full range of motion. For patients whose power is 0, for patient whose power is 1 or 2 or 3 minus, they undergo active assisted full range of motion exercises. Once the power of the patient is, or the strength of the muscles is 3 plus and 4, we go for active resisted full range of motion exercise for all the muscles. Then for motor weakness, a lot of times we use splints or orthoses, which call them in the medical language. So orthoses can be used. Most of the patients who have a stroke will either have a flail foot or a foot drop, or the plantar flexors of the foot will be spastic. So they need to use a night splint while at night on the bed, and during the day they need to use an ankle foot orthosis on AFO. Again, patients who have a tendency to go into the flexor synergy of the upper limb, their fingers and all will go into a flexed position. So for those patients, we need to use a WHO or wrist hand orthosis to keep the fingers and the wrist in the neutral position. Positioning is important because we should always keep the limbs in such a position so that the spastic muscles are stretched and the weak muscles are kept in a contracted position. Then we have electrotherapy or electrical stimulation, which is used in the initial stages of rehabilitation for muscles which power is 0. So we have generally used electrotherapy or electrical stimulation in muscles of the foot or the dorsiflexors of the foot. We have used them for shoulder subluxation for patients whom the shoulder is in a subluxated state, and also for patients who have a flexor synergy pattern. We use this electrotherapy or EST in the antagonist group of muscles. Then we have a robotic therapy. Robotic therapy is the upcoming thing because we have seen that robots are sometimes better because they do this more repetition is in a given period of time with more precision and without getting tired. So robotic therapy is definitely helpful for improving the effectiveness of the therapy. Then we have functional training where the occupational therapist is very helpful. As I said, that the functional state of the patient can be assessed on FIM scale. So occupational therapists will generally work initially for the improvement of the weakness or of the affected upper limb. But once we see that the chances of improvement has reduced, then we generally go for a once we see that the chances of improvement of power in the affected limb has reduced, then we go for teaching the compensatory techniques. One more thing is very important, that is known as CIMT or constraint induced movement therapy. That is generally practiced in patients who have developed at least power 3 in the wrist muscles and the elbow muscles. In CIMT and modified CIMT, the better side of the patient is restricted and the patient is forced to use the affected side so as to improve their power. Apart from this, a patient who have a lot of weakness and who gets fatigued easily, the occupational therapist will teach them how to go for energy saving maneuvers in doing their day-to-day activities. Then we have speech and swallow therapy. As we spoke, speech is affected. Speech and swallow are affected mostly when the dominant lobe of the brain is affected. Speech can be sensory, can be motor, can be mixed. There are 8 different types of speech involvement. it can be aphonia, it can be dysarthria. So regular speech therapy is very important, and definitely the swallow therapy. Swallow therapy generally starts once the patient's comprehension is good and they are able to understand what they are listening to or seeing. We should always keep in mind that occupational therapy and speech therapy also has some cognitive training included in them, because and generally the occupational therapy, speech therapy, and the psychologists, they work together in patients whose cognition is impaired. Swallow therapist will work first, will work, swallow therapist will assess the patient, and generally we start with oromotor movements. If the oromotor movements are good, the laryngeal movement elevation is good, then most of the times the patient is able to swallow good. Sometimes we have issues where even though the oromotor movements are good, laryngeal elevation is good, still the patients have choking spells while swallowing. So for those patients, we do sometimes FESS. Now there is behavioral therapy, cognitive training, and psychological counseling. Behavioral therapy, behavioral changes are generally seen in patients whose frontal lobes are affected. So for those patients, behavioral therapy is important, and we should always keep in mind that behavioral therapy is not generally only for the patients, it's also for the attendants. Again, cognitive training is important for patients whose cognition is impaired or higher mental functions are impaired. Psychological counseling becomes very important for the patient and the attenders too, because we have seen that a lot of patient attenders or family members have severe burnout. So they will have depression, and sometimes the patients might have suicidal tendencies. So all these things require good psychological counseling. Now comes the pain management. Pain is very common in patients of stroke, and generally there is something called shoulder hand syndrome. So most of the stroke patients complain of pain in the affected side, shoulder and the head. And there is a host of differential diagnosis for pain of the shoulders. So shoulder pain should first be diagnosed. The cause of the shoulder pain should be diagnosed, and depending upon the diagnosis, we treat the pain by using oral medication, by giving physical therapy, using electrotherapy like EST, or like using UST ultrasonic therapy or TENS. And if nothing works, then we go for intervention. Intervention means either local steroid injection or blockage of the nerves. Now, when we speak about a treatment of a stroke, the most common question that we face is what will be the prognosis and what will be the outcome for a patient, for how long the rehab should be continued. So generally it is said that the first 3 months are the golden period for any stroke patients, and rehab should be started as soon as possible. And the rate of improvement is best during the first 3 months. And generally, if we see that there has been an improvement in the power of a grade 1 or more in the first 3 weeks, we see that generally the prognosis is good. Overall, we say that the therapy should be continued for at least for an year, because whatever outcome is received at the end of 1 year is the final outcome. There have been incidences where speech have been found to be improved till a span of 2 years. Again, the part of the brain that has been affected gives us an idea about the prognosis. People generally who have a part of the brain, MCA part of the MCA artery affected, that is the middle cerebral artery is affected, we generally see that the prognosis or improvement in lower limbs is better than the upper limbs. And again, when we speak of improvement in the limbs, it's always seen that the lower muscles are recovered far late than the bigger muscles. The proximal muscles improve better than the distal muscles.